Hello, 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 everybody. Welcome to another round of Thursday VMR. I just hung out with Prof. Rez, and so I know he's not here, so I will say it is my favorite VMR on Thursdays. Um, Controversial statement, I'm sure. I just love hanging out with one of our team members and um, trying to showcase to them how brilliant and smart they are and why they're here. But I have to tell you, it's actually really hard for me to be here right now for many reasons. The first of which is just seeing the utter devastation that is happening in specific parts of the world. And I think it's really wrecked. Um, it's been hard for so many people, especially the people on the ground. But I think the ramifications of um, the tumultuous state that the world is in sometimes really hits me to the core. It makes me like just lose complete faith in humanity, and in a time where we spend a lot of time celebrating what people are capable of, it's amazing to see what horrible things people are capable of. And I'm actually very intentional in using the word people because as somebody who has family members and people they love in very close proximity to the firing line, it still is. I'm not there. I'm sitting in a very comfortable apartment, very far away, in a country that has a tremendous amount of security. And I just all that I can really say with certainty is I'm just so saddened by what um, humanity is able to do to itself. Um, I believe strongly that we are all one, and that's actually um, why it's still hard for me to do anything this week. Not to compare the angst that I feel to the people who are closer and closer and closer to it, but it's really hard. And the only things that I find easier and easier are the things that continue to remind me how cool people are and how wonderful humanity is as a counter to that force. And there's nothing better than that here. It's crazy to me that like this is literally the closest thing I've ever experienced that's even uh, close to the utopia that I think we all strive for, where literally anybody from anywhere at any time can come join. All you need is internet access. That's it. And you're a part of this community. You don't need to be a master in medicine to be here. You don't even need to be in medicine to be here, as people proven. You can be from whatever country, whatever language, whatever sexual orientation, whatever gender, whatever anything. It doesn't matter. In fact, we often celebrate non-human beings as Rabih turns his profile picture and shows us his adorable dog. I think we're all just about love and caring about people here. And so I just wanted to say that I really, really appreciate you all. I think that this space is nourishment for me. Calorically, as always, even though it's 4 p.m., I'm still having my snack and otherwise, and I'm so grateful. And nothing more ever nourishes me than meeting really, really brilliant people across the world who are very talented and very motivated. And Gerardo fits that bill. He's co-discussing for the first time today, and actually reached out to us and shared his story, which was very inspirational for us to hear and to learn more about what life has brought to him and how he's come here. And I admire him a lot. He's been part of the team, contributing ferociously despite his very busy schedule. So welcome, Gerardo. We're very, very excited for you to discuss. We're equally thrilled that Promise is here, who I was mentioning to him. I get to finally meet Promise in person this weekend. I'm very, very excited. I'm looking forward to it. But Gerardo, I'll pass the mic to you to say hello, and then we'll jump right in.
Hello, everyone. I'm so excited and nervous for today's discussions. I am ready, so let's start.
Let's do it. Promise, before you jump in the case, please tell us how your rotation is going. Just, I know you mentioned it on the student VMR, so I think people will want to know.
It's been going great. I have really enjoyed all the learning opportunities there is, and it feels like they really care about the students learning. I love the culture there. I've been learning a lot. they let me focus a lot. So I'm getting better at finding IBCs and like doing like heart focus. And then I think my favorite moments are my interactions with the patient. So I shared with the group a little earlier, got to do a little like quiz teaching session with like a patient who was an anatomy professor. And then like this morning, I was rounding on a patient who speaks Cantonese as well. And so I like spoke Cantonese with her, and then we kind of just chatted about life a little bit. And that was like really, really heartwarming. Yeah, and then one of the patients who has COVID and lymphoma, and he has to be isolated. It's just like such a privilege to be able to get his partner to go visit him for the first time in the week, and like I can just see how that uplift his spirits, and like I just so grateful for all these opportunities and experiences. Yeah.
Gerardo, you don't need me to smile, as Aisha mentioned. I think Promise will be giving you that positive reinforcement all the time. All right, Promise, take it away.
Okay, does someone want to share screen? Okay, so we have a 25-year-old female who presented with right-sided facial droop and aphasia and weakness.
What do you think, Gerardo?
Yes. So when I hear a person with right-sided facial droop, well, I immediately think if this is a peripheral cause of facial palsy, facial nerve palsy, because that would be a very benign condition which can be treated with steroids and sometimes with acyclovir. But when you have other elements that complicate the case, in this case, for example, aphasia and weakness, then you have sort of a cortical sign and a cortical or subcortical sign that can mean something more sinister that is happening to her. So the first thing that I would like to discuss in this case is if this patient has had enough cardiovascular risk factors for her to present in such an early age, because the patient is very, very young. So if this is a stroke or a TIA, in this age range, I would expect very high risk factors or otherwise secondary causes of a stroke that are not due to atherosclerotic disease, which can be a vasculitis, for example. In this age range, I would think it would be the most likely cause. So yeah, those are my initial thoughts. What do you think, Rabih?
I completely agree with you. You went from right-sided facial droop to like most common cause of right-sided facial droop is Bell's palsy, idiopathic lower motor neuron findings. But one rule of Bell's palsy, well, actually, I'll just share that there are 3 rules of Bell's palsy. It always has to be unilateral for it to be Bell's. It has to be acute in onset, but not hyperacute, and it has to be isolated, meaning the patient has no systemic symptoms and no other neurological symptoms. So 3 rules of Bell's: unilateral, acute, but not hyperacute, and isolated systemically and neurologically. And boom, that 3rd rule is broken because it's not isolated neurologically. So therefore, it cannot be Bell's. And then you're right. Aphasia makes it a cortical issue. I know that you are a neuroaficionado. So I'm curious what advice you can give us about when a patient has a speech issue. They don't say they have aphasia. Promise is helping us a little bit by translating for us. So can you give us some tips on how you go about translating a patient saying, I'm not speaking well, into a diagnosis? Because aphasia is a diagnosis, right? So tell us how you go about doing that.
Yes, exactly. Well, if a patient has a problem with the speaking, then we have to decide if the patient has a problem specifically with language or articulation of the language. And in that case, it would be called dysarthria and not aphasia. And aphasia is about language impairment, but there is multiple types of aphasias. I think that there is like 9 or more. So they can be differentiated, and if you continuously test different abilities that involve language. One of them could be comprehension. For example, if you ask the patient to, I don't know, touch the tip of their nose with the right finger, then if the patient is able to do so, then that would lead us to another type of aphasia. Or if the patient is able to speak fluently, but what he is or in this case she is speaking doesn't make sense, well, that would lead us into another type of aphasia, which would be Wernicke's, and so on. There's actually a systematic approach to that, but I remember comprehension, writing, and reading. Yes, that's what
That's
comes to my
superb.
mind, to the top of my mind. Yes,
That's absolutely superb. I think that your distinction first is, say, aphasia versus dysarthria, and then what kinds of aphasia, and also there turns out to be that there are kinds of dysarthrias as well. But I think for most generalists, the hardest thing to do is to try to distinguish aphasia from dysarthria. And fundamentally, as you just said, aphasia is a problem with what the person is saying. What are they saying? Dysarthria is a problem with how they are saying it. Aphasia, my patient has a problem with what to say. Dysarthria, my patient has a problem knowing how to say it. And how can you go about this in real life? Just pretend that you can put subtitles on for your patient. And a patient with dysarthria, if you put subtitles, like you do on watching Netflix maybe, you'll be able to understand exactly what they're saying. But in aphasia, subtitles would not fix the problem. It still would not make sense. And you have to be careful. It would not make sense because the sentence is illogical, or it would not make sense because it doesn't mean it's completely mumbo jumbo made up. So there's expressive aphasia, in which the subtitles don't make sense because the patient's missing words, has paraphrasing errors, or it doesn't make sense because you asked one question about the weather and the patient's talking about sharks and whales. They have an impaired comprehension. And then you're right, Gerardo. There's types, many different types of aphasia that have to do with a complex interaction between the frontal lobe and the temporal lobe and different lesions across that space that actually I don't keep track of, because when we've made the distinction between aphasia and dysarthria, fundamentally aphasia is a frontotemporal cortical problem, which an expert can localize with more precision. Dysarthria, in stark contrast, is a much more diffuse localization and needs more to localize. So final question for you. In the first minute of taking care of this patient, right now in the first minute, if you could have one more piece of data about this patient's HPI, what would you want to know? So far, we know she is 25, she has right side of facial droop, aphasia, and weakness. What is the next piece of data you would like to ask her in your conversation that may help you think about her?
Well, I don't think it is part of the HPI, but past medical history that would lead me or make me think of secondary causes of stroke. Yes.
Watch this, Gerardo. Watch this, okay? Watch what our minds assume when we don't have data. Let me tell you this. 25-year-old female presents with right-sided facial droop, aphasia, and weakness for 3.5 years.
Okay. Time course.
Yes. Tell us why that's important.
Yes, well, time course because it can differentiate. It is very important in the diagnosis, especially neuro. No? If it is hyperacute, then we can think of a vascular cause. If it is subacute, it can be, I don't know, an infection, or it can be structural. If it depends on the mass, on the type of the mass, but it helps to differentiate in the differential diagnosis.
Amazing. Now I have a piece of advice for you. So in medical school, you're taught that if you get something wrong, that's bad, that you should feel bad about it, which you may be feeling bad. Oh, you know, I should have said time course, not past medical history. But actually, there's some learning in that. So why do you think you assume the time course is compatible with a stroke? Why do you think your mind did that?
Maybe because the clinical presentation screams of
Yeah.
a stroke. That is unbiased, no? A type of an anchoring bias, I think.
A bias is only if you refuse to update your thinking given more data. So it's not a bias. It's not like the patient said 3 years and you said, no, it must be 3 hours. That's a bias. So what you did is a wise cognitive assumption, which is you said, I'm going to assume acute for 2 reasons. One, most people, if they get this, they'll come right away, you know? And 2, if you don't know data point, you should assume it is compatible with more serious things until proven otherwise. So instead of criticizing oneself for not knowing why you did one thing, it's worth studying why our minds go certain places. In this case, you should assume until proven otherwise that this person is presenting hyperacutely, and the assumption is because it's most deadly this way, most intervenable, and it's most probable, but we don't know, and we'll see. All right, Promise, tell us more, please.
Yeah, so if it's okay, I want to go up to physical exam for the second aliquot. And then because this is the outside hospital records and I don't have access to EMR right now, I'll just go off of what I remember and feel free to ask for specific things on physical exam if that's okay. Okay, so this is a 25-year-old female with no known past medical history who's brought in by EMS for a possible CVA. She had 2 weeks of vague flu-like symptoms, and then some short of breath, intermittent headache, took Theraflu, and then the partner also mentioned that she feels a little more restless and seems like some changes in her behavior. And then she was actually doing well 2 hours before arrival. On arrival, she had right whole body paralysis, white facial droop, aphasia, right arm and right leg profound paralysis. And in terms of, let's see, so for past medical history, there's no known past medical history. She's not taking any medication. Family histories, apparently there are a couple young family members with some sort of kidney disease, but they weren't able to say what it is. And some people are on dialysis. And then in terms of social history and health related behaviors, pretty unremarkable, denies any smoking, alcohol use, or any like stimulant, recreational drug use, no recent traveling, doesn't seem like there's any recent trigger, and then no known allergies. For vitals, her temperature was afebrile, her heart rate was around 80s, and then her blood pressure was 180 over 127. She is sitting on room air at 93%. And then for physical exam, notable for like a right side paralysis, and then you can see facial droop, her cranial nerves, her pupils were, the left pupil is constricted, and then the right side weakness is like 2 out of 5, and then left is 5 out of 5. In terms of heart is regular rate rhythm, and then for pulmonary exam, there's actually some crackles noted.
I promise this is super helpful. I just want to clarify one thing. So just to get the HPI right, it sounds like she's had 2 weeks of shortness of breath, headache, and behavioral changes followed by a hyperacute localized syndrome that you're giving us on exam. Is that fair to say?
Yes.
And awesome. That's super helpful. And then can I clarify, what was the diastolic blood pressure? I heard the systolic was 120. I missed the diastolic.
Oh, sorry. It's 127 for diastolic. Systolic is
Oh, I see.
180
over 127. Super helpful. And then what was her mental status like at this point? Did you see any corroboration of that behavior change, or was it not perceptible on the initial exam?
So that's actually, this is like a presentation at the outside hospital. So I
Okay.
don't have
No problem.
mental status with that.
Yeah. No problem. Okay, no problem. Cool. All right, Gerardo, what I got you some time to think. Very, very tricky. What are your thoughts?
Yes, so and I have sort of a lot of things in mind at the moment, but I will try to like sort of summarize all that is in my mind. So in my first intervention, I said that I would look for risk factors for a stroke caused by atherosclerotic disease, but here I don't see any. So it must be a stroke caused by other by other type of disease processes. So here in this patient that we see very a lot of signs that indicate a focal process, then I would think about some common causes for a vascular event that are not related to atherosclerotic disease, and that would be, for example, an antiphospholipid syndrome that is a cause that is relevant in this age range. So I would look for antiphospholipid syndrome, and then I would look for signs of or history of lupus, which is really associated with antiphospholipid syndrome. Those are two diseases that come to mind, but what it doesn't really connect with this hypothesis is the shortness of breath and intermittent headache, which in the current presentation are not really indicative of anything and not very specific. I can think that for maybe antiphospholipid syndrome can cause some pulmonary involvement in the form of chronic thromboembolism, but that's the only connection that I find. And for the very high blood pressure, two things come to mind. In the when there is an ischemic event in the brain, it depends on the extension, but the one mechanism that the body has to protect the brain is to increase blood pressure. So that could be a physiological response to an ischemic event. And in this case, for example, that there is very severe focal neurologic signs, it most likely is because of the vascular event in the brain. So I think that it is a consequence and not a cause of the presentation of this patient. Those are my thoughts. What do you think, Rabih?
I love it. I love it. You're like went with your reflex thoughts of two very interesting diseases to like very focused on what this situation shows. And I think that if you were to remove everything from this case and pretend like you just walked in to this situation without knowing the history of the 2 weeks of issues, you would be like, this is a tricky localization, because she is having right-sided paralysis with a right-sided facial droop, implicating the right side of her brain stem, right? But then she has left pupillary constriction, which might suggest a Horner syndrome involving the left side of her brainstem, right? And then she also has aphasia, we're told, which is a cortical phenomenon. So I'm having trouble localizing where this problem is. So right-sided paralysis implies either
Yes.
yeah, what do you think about, so let's study the localization a little bit. So aphasia, cortical phenomena. It could be possible that the aphasia is being misinterpreted and the patient has dysarthria, which would be very much fitting a brainstem issue and a cranial nerve issue. The fact that she's having right-sided paralysis on the same side that she's having her facial droop and not having crossed signs is very intriguing, which may mean that she has a lesion. Yeah, I'm having a hard time localizing the lesion reflexively, but I think the most important thing here is to recognize that in the acute moment, you probably have to ignore temporarily the subacute symptoms and say, this is abrupt in onset, is devastating. I'm going to assume it's vascular until proven otherwise. And the reason her mental status is so important, because if you also learn that she is having an altered sensorium, you would then probably prioritize a hemorrhagic stroke over an ischemic stroke. But the question will always be, why? Twofold. What does her subacute symptoms of shortness of breath, behavior changes, and headaches symbolize? And what is the fact that she is having concomitant cardiopulmonary disease as evidenced by her hypoxemia? What does that mean? And I'll just say that a hyperacute syndrome superimposed upon a subacute syndrome may mean that she has mass forming disease from an abscess, from a cancer that either bled, that caused a seizure, or caused obstruction through hydrocephalus. So her subacute symptoms are more in line with the possibility of a mass-like disease process in her brain. However, a vascular hypothesis such as an ischemic or hemorrhagic stroke is not incompatible with hyperacute superimposed on subacute. How might that happen? If you have multiple embolic events, multiple embolic disease can actually show up as headache and behavioral changes. And then a superimposed, more prominent focal syndrome can ensue. So I think the question really is, Gerardo, are we dealing with a mass-like disease process that has been complicated by hemorrhage, complicated by seizure, or complicated by obstruction? Or are we dealing with a acute on subacute vascular process and the subacute component being diffuse shower of emboli causing headache and encephalopathy with a punctuated by a hyperacute syndrome? So I'm really curious to see what her x-ray in the chest looks like. Because if we see a big mass, then we're probably going to assume that what's happening in her lung is a mass-like process. If, however, we get a chest x-ray in 1 minute and we see pulmonary edema, we might then think, does she have a vascular process such as a cardioembolic disease? So the tension really in this case is brought up by the subacute disease process, which brings to light mass-forming issues, but a subacute disease process is not incompatible with a vascular imprint. So I'm really, really curious to see what Promise gives us next. Do you have any other thoughts to add, Gerardo?
Yes, one thing that I think it would be worth mentioning is that some mass processes can present somewhat like this, and for that we need more information regarding the pupil examination. Is it true that the left pupil is constricted in relation of the right pupil, or is it that the right pupil is dilated and we are sort of like interpreting wrong the examination. And that is important because, as you said, if you have a right-sided paralysis and a right facial droop, and normally we would expect a cross signs, but in this case, I think it points more towards a cortical process, and a cortical process, if it is severe enough, it can cause mass symptoms, and that actually have a name, that like the Kernohan syndrome, when you compress the upper portion of the brainstem, which is the midbrain, against the tentorium cerebelli, which is this structure that is hard, and in that way you can cause symptoms on the other part of the brainstem that is called the Kernohan syndrome. So that would be a suspicion that we can have, but also I really would like to know the state of the consciousness of the person, because for that mass to have that effect, it must compress the hypothalamus and cause really altered mental status. So that is something that we have to have into consideration. Yes.
You're spoken like a seasoned neurologist. I think that's an absolutely brilliant pearl. Thank you for sharing. Wonderful. Aisha, if you can tell, I'm really smiling, by the way. All right, Promise, tell us more.
Okay, just because of how extensive the workup has been, I'm going to give quite a lot of information in the next aliquot to be aware of time. So this is still everything in the outside hospital at this point. So they did a CT and it showed focal intraparenchymal hematoma in the left basal ganglia centered on the external capsule, measuring 5 times 2 times 3 centimeters. There's surrounding hypoattenuation consistent with edema and local mass effect seen in the left lateral ventricle. There's also a left to right midline shift. And then with regards to the chest x-ray, they see pulmonary edema there. And then they also at the same time did an echo, which showed a ejection fraction of 43%. Her BMP is pretty out of whack. I would say all the electrolytes are pretty imbalanced, and most notably, her creatinine is 8.7. She doesn't have a baseline, but yes, it was never checked with her baseline. And then in terms of her CBC, her hemoglobin is 8.8. Other than that, it's unremarkable at this point. Let me see. Is there any other studies that you want me to go through right now?
I think that's awesome. That's a great place to start, Promise.
Oh, actually, let me add 2 things. Her high sensitivity trope peaked at 36.4, and her BMP is also elevated.
Awesome. All right, Gerardo, you want to start off with the neuro? And we can talk about the systemic in a moment. So what did you think of the neurological findings on the CT?
Yes. If I've not heard wrong, you said, Promise, you said that the mass of the hematoma was in the internal capsule.
It's the left basal ganglia and external capsule.
Left basal ganglia. So if we find this lesion, and if we just see that lesion, we would assume that it is a case of a patient with chronic hypertension that it is not being controlled, because that is some characteristic lesion of hypertension, but the patient doesn't have a past medical history and she is very young. So that is the first thing that comes to mind. If it is already established that it is an intracerebral hemorrhage in that region, well, we know based on the findings that it is a very large mass for it to cause, because small lesions don't really cause cortical signs, and that is why, like, a rule that it is not always like the case, but in the when it is large, we can assume that the patient can present with cortical signs. And well, apart from that finding, I think that something important about the chemistry is the creatinine, because we also have a patient with family history of CKD. So what comes to mind is some causes that can relate kidney disease with problems in the brain. And one etiology that comes to mind is polycystic kidney disease, because that is that can present with a vascular event in the brain, although the most common presentation would be a subarachnoid hemorrhage, and that is not the case here. But that is one thing that comes to my mind, and that is my initial comment on this situation. What do you think about that?
I think it's absolutely amazing that you're discussing this case as if you're a resident, quite frankly, and I completely agree with you. I think that now we've have more clarity. This is a vascular event, and you saw, Gerardo, I realized something that I have to learn better at. Earlier we were saying vascular versus mass, but look how beautiful this case is. This is a vascular process with mass-like effect, and see how cool that is. Because we were trying to see, is it a mass or is it vascular? Actually, it's both. It's a vascular issue that has resulted in mass effect. And I think that's a very elegant answer to our issue. And so now we have a problem to solve, which is what are causes of an intraparenchymal hemorrhage? And it's true that there's a short list of common causes we should all think about in intraparenchymal hemorrhage. And you can filter that down by location, but in all comers, trauma is a very important cause. Microvascular disease as a result of diabetes and hypertension, and then finally anticoagulation-related bleeding. And this patient is not on anticoagulation and does not have trauma, implicating the possibility of small vessel disease. Of course, there are other issues that can cause bleeding, including arteriovenous malformations, aneurysms, dural venous sinus thromboses, amyloid angiopathy, many things. But practically speaking, we have the combination of hypertension and intraparenchymal hemorrhage in the basal ganglia, very suggestive of small vessel hemorrhage. But your caveat is important. You said that the blood pressure could be high, not chronically, but as a result of this person's acute intracranial hemorrhage and the subsequent compensatory mechanisms. But Gerardo, if we learn later that the patient has long-standing hypertension, but just has never been seen because she's only 25, that changes things dramatically. And all of a sudden, it's actually very easy to figure out why this person had intraparenchymal hemorrhage from long-standing hypertension. So one big teaching point is, how do we go about collecting clues as to the time course of hypertension? So what do you think about that in general? What are the physical exam or EKG or test manifestations that you can try to build a case for more long-standing hypertension? What do you think about that?
Yes, first, an exam that is really cheap and we have to make in every patient that we are doubting the history of the hypertension would be the fundoscopy. We look at the eyes and see if we find chronic changes in the retina that can point to chronic hypertension. Also, and the history of the kidney function, because that is an organ that is also damaged in hypertension. Also, for example, in the EKG, you can find signs of hypertrophy of the left ventricle because of the increased afterload that comes with hypertension. And yes, that is what I would think.
Right. Superb. I couldn't agree more with you. I think looking at this EKG for left ventricular hypertrophy right there in the moment will be very, very helpful. And all of a sudden, we would basically translate this into a problem saying, why does this patient have long-standing hypertension? And that would explain her heart issues. That would explain everything, really. And the tricky thing is how to relate that to her kidneys. you can draw a circle between hypertension and kidney issues, because hypertension can cause kidney issues, and kidney issues of any cause can result in hypertension. But more recently, many people are doubting whether isolated long-standing hypertension alone is sufficient to cause kidney failure. And that connection is being strongly debated in the literature. So I think our operating assumption in this case would be that this person has really, really bad chronic kidney disease, and that chronic kidney disease has resulted in hypertension and its devastating consequences. And of course, that line of thinking is strongly reinforced by the presence of her family history. So I'm curious, Gerardo, how do you think, or what is your approach to patients with, in general, with chronic kidney disease? What do you know about that situation?
Well, in patients with chronic kidney disease, we know that the three main causes of that would be first, diabetes, that is like about 40%. Then we have hypertension, which is 20 to 30%, and then we have glomerulonephritis, which can be secondary or primary. And then, well, that would be my approach. No,
Superb. I think one more familiar approach to people is acute kidney injury. And so you can ask yourself, how can I make CKD easier for me by borrowing from my acute kidney injury? And the long story is there is no pre-renal cause of chronic kidney disease. It doesn't occur. There are post-renal causes, and the post-renal causes affect the interstitium of the kidney. Chronic hypertension on the interstitium results in interstitial nephropathy. So CKD is just all the intrinsic AKI categories: glomerular, tubular, interstitial, with a nod to obstruction causing interstitial, and then vascular. And that's the approach that we should take. And the questions are, what are the most common causes in general? And then finally, what are the most common causes that are maybe familial in nature? And those, I think, are going to be the active questions to understand this case better. But I will just say, it's kind of crazy, Gerardo, that here we have before us a intracranial hemorrhage patient, and we're discussing, and we believe that the answer lies in her kidneys. It's crazy. And I think because we've gone so far down the chain of thinking, we have to be careful that we might have made an error in our line of thinking and be open to her having a non-hypertensive related bleed, and be open to the fact that another cause of hypertension may have impacted her kidneys, like hyperaldosteronism or pheochromocytoma or something else. So there are many things that we have to keep in the air. So let's get more data to see how we're doing.
Yes. Yes, one final comment. Can I make one final comment? Yes, previous to like this new data, like I was forgetting about my first suspicion for the etiology, because like I know that lupus can really mimic anything, but if we have really bad renal involvement and also pulmonary involvement and an intracranial hemorrhage, and those are consistent with the endothelial damage that can be accompanied by in a patient with lupus. So that would be really a strong suspicion for me. So I'm curious to know more data.
Yeah, this is an incredible discussion, and I'm just so impressed by how far, Gerardo, you've made in your thinking. Let me just say, for the purpose of this morning report, I think it's better if we just focus on the diagnosis side. The managing side is also a ton going on. So for the diagnosis side, there's like an extensive workup with secondary hypertension. Let me just give you some numbers. So in terms of the pheochromocytoma, they worked up metanephrine is normal, normetanephrine is elevated, in 24 hours is 683, and then the 24-hour urine metanephrine is elevated at 830. And then they also did, the aldosterone is elevated at 32. Renin is normal in 2.58. The ratio of aldosterone to renin is 12.4. And then TSH is normal. They did a renal ultrasound showing that right greater than left renal atrophy, no hydronephrosis. And then they also did some intracranial and extracranial angiogram, which is normal. They did a CT angio of head and neck. It just showed that the lung showed consistent with chest X-ray show ground gas opacity in the right upper lobe and left upper lobe. And then they also incidentally found enlarged mediastinal lymph nodes. And like in terms of head findings, pretty consistent with the CT. They repeated an echo 2 days later, and her ejection fraction has decreased down to 35%. And then they did a UA, which showed 3+ proteins, 8 white blood cells, and 9 RBCs. And then there is a urine protein that's 170.9, which is slightly elevated. And then 24-hour urine is 2,800, which is very elevated. Do you guys want the kidney biopsy results?
Yeah, Gerardo, I'm curious. Maybe you can just ask one question because we're running short on time. Is what compartment of the kidney do you think is involved in the CKD? What do you think?
Well,
I know you're in your comfort zone of neurology. Now you're like, oh no.
no, if I'm not mistaken, like the glomeruli are damaged in hypertension. So the glomerulus.
Yes, I think the hypertension is in fact a glomerular disease, and then here the amount of proteinuria is suggests glomerular disease.
Also the casts. But sorry, were you about to ask something?
No, I'm clear. Go ahead, please.
Yes, because I didn't hear really well the ultrasound results. The
kidneys
can
are
you repeat?
Small. Basically, there are small kidneys and no hydronephrosis.
No hydronephrosis. Both kidneys are small.
Yes, asymmetrically so, but both are small.
The right side is more atrophied than the left.
So 2 things come to mind. Because if we see one kidney atrophied and the other isn't, in a young patient, we can think about fibromuscular dysplasia, which is a cause of secondary hypertension, which we were searching for. But in this case, it's bilateral, which does not exclude that possibility, but I think makes it more unlikely. Also, if it was the case that this is a case of pheochromocytoma, then we would find a mass above the kidneys, I think, because that is where a pheochromocytoma would be, and I think that would show up in the ultrasound. But that's a guess. I don't really know. But that is not the only place that you can find a mass that secretes catecholamines, because you can find paragangliomas, which can like show up almost in any place. But so I'm curious about the lymphadenopathy that it was reported on the by the radiologist. And those are my thoughts. Yes.
I love it. Absolutely super. I think all those things are leads that you should pursue. The problem with the metanephrines is that a mild or moderate elevations in metanephrines are more likely noise than they are signal. So the how elevated they are is very informative. I don't know if they're super elevated here, but you're right. Just because you don't see an adrenal mass doesn't mean the patient doesn't have a catecholamine secreting tumor. So that's a caveat. The height of the normetanephrine elevation is very, very important. I don't know what the normal is, and it honestly doesn't matter. because you have to look at the kidney and see what's going on with the kidney anyway, because PHIOs presenting with renal failure is very, very unusual. The mediastinal lymphadenopathy is a very interesting lead for you to follow, and it could be definitely represent a misinterpreted lymph node that actually is a paraganglioma. The caveat to that is that we know this patient's in heart failure, and in patients with heart failure, the pulmonary edema, the low echo, they not only get venous engorgement and venous hypertension, they also get lymphatic hypertension. And so isolated mediastinal lymphadenopathy, if it's isolated to the drainage loans of the left heart, can be a feature of left heart failure. So that wouldn't apply if the patient has more disseminated lymphadenopathy. But here, this case illustrates distinguishing signal from noise is very, very hard. Are the metanephrines real and symbolic of a PHIO or a paraganglioma? And are we dealing with an intrinsic lymph node disease? Tough to know, because equally plausible explanations are that the metanephrines are noise because they're low-level elevations, and that this is just lymphatic congestion from the left heart failure that she has. I really believe that the height of the kidney dysfunction at this patient's age, along with her degree of proteinuria, tells you that the kidney is probably the most likely signal, and the rest, if it's noise or not, will probably be determined on what diagnosis we render on the kidney. Does that make sense?
Yes. Yes.
Awesome. Okay. Terrific. Promise, tell us more.
Okay. So let's see. The ANA titer is high 1 to 80. The titer pattern is cytoplasmic, dense, fine speckled, and then mitotic intercellular bridge. And then the kidney biopsy showed diffuse global glomerulosclerosis with severe interstitial fibrosis and tubular atrophy and severe arterial and arteriolosclerosis, and no evidence of primary immune complex mediated glomerulonephritis and our FSGS.
So, well, the first thing that I would say would be that we know that the ANA is a sensitive exam, but it is not a very specific exam for lupus. So that finding serves to rule out lupus, but in this case, we have to be cautious interpreting it. So, and also we know that lupus is the main pathophysiology behind renal involvement is the immune complex mediated form. So I am assuming that an immunofluorescence was performed in order to rule out the complement mediated pathophysiology. And well, if it is not lupus, which is causing the diffuse glomerulosclerosis, it can be secondary to the hypertension, the chronic hypertension that this patient might have. So I'm curious to know, like, your hypothesis behind that kidney results.
Yeah, I think it's very, very tricky because you have glomerular involvement, but you also have, as Promise mentioned, she has diffuse glomerular sclerosis, and she has chronic tubular interstitial disease as well. So both compartments are affected. And I think that in the absence of immune complex deposition, it's hard to invoke an immune complex mediated process such as lupus, which makes the validity of that ANA more likely noise than signal, but still possible. In the face of her, so the question becomes what causes glomerular disease and what causes tubular interstitial disease. And then in the context of the family history here, there's a whole variety of genetic conditions that can do this, including ones that are worth remembering, like sickle cell disease and Fabry's disease, and many other syndromes that are well beyond my understanding. But for me, I think the combination, the chronic tubular interstitial disease and the non-inflammatory glomerulosclerosis are more likely for me to suggest a genetic condition of chronic kidney disease that's either named or unnamed. And I know from a little experience that many of these conditions actually are hard to diagnose I know Promise shared with us beforehand and privately that this case may not have a definitive answer, and that's actually reflective of this space. Many chronic tubular interstitial diseases in particular, and non-inflammatory glomerular diseases, are congenital without a specific diagnosis. So if I'm being honest, I think that what would happen in real life for me is I would probably lean heavily on the smartest person in the room for this case, which would probably be a pediatric nephrologist, which is quite the inference to make, to say this person who's 25, who came in with a devastating neurological syndrome, ultimately blaming it on the kidneys, in large part because these biopsy findings are not fully compatible with just the effects of hypertension on the kidney, particularly the tubular interstitial changes. So
Yes.
for me, I think the underlying common denominator here is probably either a heritable genetic syndrome that is named, or one that is yet to be fully elucidated. Any other thoughts, Gerardo, before we learn from Promise?
Well, but I remember from, for example, Fabry disease, it would present with another findings like peripheral neuropathy, angiokeratomas, and anhidrosis, I think. So that would make that unlikely. And also, well, just to make another comment about where my mind went with this presentation about the interstitial involvement. I know that some monoclonal gammopathies can cause interstitial involvement, and the damage that they cause are not complement mediated. And that can just justify the lymph node involvement. But that is where what popped into my head. But monoclonal gammopathies are actually possible in young people, but obviously they are more common in older patients. But one test that is very cheap and can be very useful would be a complete protein exam and electrophoresis with immune fixation, just to see if we have like a monoclonal spike that can suggest that possibility. Yes.
I love it. Absolutely superb. Your knowledge is far, wide, and deep. I love it. I promise. Where were you all at with this case?
Before I go further, I have a question. How suspicious are you guys of like renal arterial stenosis or like fibromuscular dysplasia?
Well, what I have to say about that is that, for example, in renal artery stenosis, we know that the main cause would be atherosclerosis, which if it involves the renal artery, then it most likely involves other arteries, and we can find signs of arterial insufficiency elsewhere. And for fibromuscular dysplasia, we can make an exam, which would be an angiography, to search for the pattern of the string of pearls that it is characteristic of that disease. And now, for example, I was thinking about vasculitis, like compromising also the renal arteries, but I know that what we are getting right now aren't really suggestive of a vasculitis syndrome, when not one that I know, like at this point. Yes.
Yeah, I completely agree with you, Gerardo. I think it's helpful to conceptualize the presentations of both those vascular conditions as more devastating consequences of hypertension. And it's very unusual at such a young age for anyone with even premature atherosclerosis and fibromuscular dysplasia to have such devastating consequences on their kidney. Those patients often present with refractory hypertension or devastating intracranial consequences, either from the hypertension or from the concomitant disease, either fibromuscular or atherosclerotic. And so I think the inlet into that hypothesis is that there's relative asymmetry in the kidney size. And so you might wonder, is there a strategic lesion in one of those two kidneys? But I think that the age of the patient reduces the possibility of atherosclerosis, and the presentation of advanced kidney failure in the context of fibromuscular dysplasia is relatively unusual, with the more common presentation being early refractory hypertension or intracranial events, though it's still possible in this case for sure. All right, promise, Mike, to you.
So she's like stabilized, a lot of consultants are on board. And when she transferred to my hospital, currently we sent like C3, 4, and then amyloid, so SPEP, PPEP. Those are pending, and we're trying to work up why she's having like a IDA, but we have like similar thoughts, thinking like it could be some sort of genetics, Fabry's, or some unnamed genetic disease. And I think we like initially our hypotheses were kind of like, could it be like what we talked about, like a kidney process causing this hypertension, brain bleed, and then like, hyperacute heart failure, and like nephrotic syndrome. We try to figure out if it's like vasculitis. That's like another hypothesis we had. There's also some thought on like myocarditis, but I think right now it's pretty like the working diagnosis is a chronic kidney disease of unknown cause, either is like from long-standing uncontrolled hypertension. We're trying to get their previous like clinic record right now. Don't have that yet, but at the same time, we don't think unless it's very unlikely for a 25-year-old to have chronic hypertension to present at this point, because usually people would have chronic uncontrolled hypertension at 50s or 60s to start having this type of presentation. So probably some congenital genetic disease that we don't know of. That's our thought right now. And then I think like this is actually not my patient, it's someone on the team, but I just really wanted to figure out what's going on and kind of like did a lot of research, try to look through case reports. And I found something I found like case reports on like polyimmune glomerulonephritis, also like like ANA negative lupus nephritis, just trying to figure out what's going on. But I think like right now I just have to settle the fact that I won't know enough.
Oh, go ahead, Paul. Sorry.
I was just gonna say, but if you want, I can share a couple things that I found from my research. Otherwise, I will let you guys reflect.
No, tell us what you found.
So I found that when it comes to like interstitial fibrosis, tubular atrophy with the biopsy, the differential kind of like the most common is actually hypertension, calcineurin inhibitor, and then lupus nephritis, which is also happens to be the most common causes of if you see like severe arteriolosclerosis on a kidney biopsy. And then kind of some of the things that I also looked up, I was like looking at pathology journals, and they were saying like global glomerulosclerosis usually happens in end-stage kidney disease, which unfortunately is what our patient has. Tend to be either end-stage FSGS or glomerulonephritis, and they can sometimes be polyimmune or biopsy negative. And then in terms of kind of like the ANA causes, something I learned is like the 1 to 80 titer doesn't mean so much, like you guys discussed. Like I think it's like 40%. There's like a chart that shows like the percent of population could test positive for 1 to 80. And it's only when you go higher titers that could be more specific. And then the top kind of like differential for that is like autoimmune, like lupus, vasculitis, it can be Sjorgen's, and then infection, and then or like thyroid disease. And then in terms of like immune complex glomerulonephritis. The top causes would be lupus nephritis, IgA nephropathy, non-specific granular, like complement-induced nephropathy. So it's just really, really, yeah, I try to do a lot of research to figure out what's going on. But I think it's really helpful to see, like, build these differentials out of these data.
I admire both of you so much because both of you are in your latter stages of your medical school training, and it's amazing for people to see just how rich and deep a conversation you can have when you're so early in your training. And promise, your curiosity to like figure out what this patient has is so palpable. She's not even your patient, and you don't even have an answer yet, and yet you're so passionate about getting clarity. And I think all of you listening to this conversation can see how passionate Gerardo was to try to find an answer for this person. And I think with age that I have, you just know when the investment is not probably going to be productive, in large part because this, not because there isn't an answer. Don't get us wrong. When we watch this tape, maybe 20 years from now, we'll be like a little embarrassed. Maybe like, oh, how could we miss this very like classic presentation of this yet to be described disease? But I think whenever you settle on this on this specific space, I think the probability of that, unfortunately, in today is still high. I will pass the mic to Bettina in a moment, but I wanted to. I'll share one final reflection, but I want to hear how it felt for you, Gerardo, and what you learned from this case.
Yes, so I think that it was a very wonderful case. Even though we don't have a final diagnosis, I think that the most interesting part of medicine is like trying to figure out the diagnosis. So if there isn't an answer, that actually makes our mind think more of the possibilities. So I felt very excited throughout the case. In the first time I thought that it was a typical presentation of just a stroke, but it turns out it led us to really really wonderful discussion with a lot of differentials to think about. So I'm very grateful for this opportunity and really looking forward to what is of the outcome, or the final outcome of the patient. And I hope that Promise let us know. Yes, thank you very much.
I'm sure you'll be texting each other with curiosity. I just want to share. I just wanted to share how cool it is to see so many people contributing to this effort. I'm excited for Bettina's teaching points. I'm very grateful for Jimena to scribe, and promise your cases keep bamboozling us. Student VMR was incredible. In case people look at the whiteboard, I don't want to spoil it. And Gerardo, your conversation today, you like literally. I know you're entering the clinical realm very soon, and it's almost like you've been seeing patients throughout your life. It was really quite remarkable. I'll just tell you that the ultimate clue to the disappointing return in diagnostic investment in this patient, the likely, is actually the fact that the patient does not, in patients with kidney disease, when they have extrarenal manifestations, they occur for two reasons. The first is they have consequences of the body's adaptation to renal failure. So hypertension, hyperkalemia, acidosis, those cause issues elsewhere, but they are not specific to the underlying cause of kidney disease. They occur from kidney disease of any flavor. Hyperkalemia, acidosis, hypertension, encephalopathy, right? But then you can have a systemic disease that affects the kidney and also affects the rest of the body in a manner specific to the disease entity. For example, multiple myeloma causing kidney failure will cause hypercalcemia, a consequence not of kidney failure. So if you study this patient's syndrome, she has two cardinal clues to the lack of diagnostic specificity. The first is she has absolutely no unique features of a systemic disease affecting the rest of her body. All of her complications can be readily attributed to the consequences of adapting to kidney dysfunction. All of them, the heart, the brain, the blood pressure, everything. But there's another clue. Not only does she have isolated renal disease with secondary complications on the rest of the body, this kidney failure is at least 5 to 7 years old. And the way you know that is the depth of the creatinine, with the depth of the heart failure, with the depth of the LV thickness. This kidney failure is chronic, not subacute, truly chronic. So the probability of a specific diagnostic entity in a long-standing renal failure without systemic diseases with a unique fingerprint just tell you that the kidney itself is failing and basically has early dementia of the kidney. And those cases, unfortunately, are often idiopathic and or genetic with unknown yet to be described mutations, or mutations that are being recently described that may not be accessible to many parts of the world, even in the United States. So those are the clues to the anticipated low yield of diagnostic return. The long-standing nature of this disease as evidenced by the devastating consequences this patient has, and the lack of unique markers of Fabry's, of unique markers of myeloma anywhere else. So I think if I were to vocalize that, that's probably why, just to pass on that knowledge. But that shouldn't deter both of you from trying to like see if this case is the exception to that. But definitely the base rate in this case would say you probably either need a super expert like a pediatric nephrologist, or there is no answer out there. Anyway, with that ramble, I just wanted to put that in light. Bettina, please take it away.
Thank you so much, Rabih. I'm so happy to do the TVs for today because this was such an incredible practice of what you say, distinguishing signal from the noise, like what we experience with the ANA, with hypertension and the catecholamines, and how to avoid bias, which in Rabih's words happens only when you refuse to update your thinking given more data. So I'd like to thank Gerardo because I learned so much from you today, and I'm so excited to share the main teaching points from your discussion with Rabih. So first is that one way to approach aphasia is to first distinguish aphasia, which is a problem with what the person is actually saying, versus dysarthria, which is a problem with how to say something. And then from there, we can check the patient's comprehension, fluency, writing and reading ability, and repetition ability to further delineate which type of aphasia we may be dealing with. And then another teaching point that is important is that a hyperacute syndrome superimposed upon a subacute syndrome may mean that a patient may have mass-forming disease like an abscess or cancer that can either bleed, cause a seizure, or cause obstruction. And then another possible explanation is what Gerardo called the Kernohan syndrome, which is a lesion causing mass effect on the contralateral midbrain against the cerebellar tentorium. And then our patient notably presented with hypertension, which may be either due to a compensatory mechanism to ischemic events, but even in a patient who is just 25 years old, it can be chronic in nature. And so we can look for signs like retinal changes, like nicking and exudates, kidney damage with the creatinine, and left ventricular hypertrophy on EKG. And then one last main teaching point would be that CKD can have a lot of causes depending on age, depending on the context of the patient. It could be familial or congenital, which might be the case in our patient, that can usually present with non-inflammatory glomerulosclerosis and tubular interstitial changes. But other things that we can look out for would be intrinsic etiologies like from hypertension, diabetes, glomerulonephritis, or post-renal causes like interstitial nephropathy. And other things to look out for would be sickle cell disease, Fabry disease, and gammopathies. So those are the main teaching points today.
Absolutely amazing. You're so smooth. You're like just from point to point to point to point. That was amazing. Welcome back to VMR Teaching Points. You have lost nothing since your time studying for Step 3. All right, y'all. Thank you for joining today, and I hope you have a wonderful rest of your day. All right.